Here. Thanks very much, Jeff. Hello, everybody. I must say I'm doing this talk knowing that Jeff over here has done this talk at EMIS National User Groups very, very well, and so I'm trying to follow the master on this topic. The reason why I think I was asked is that I have a college role, which is about producing guidance, which is on the e-learning website for the college, about all things patient online, as far as access, appointments, and prescriptions are concerned. And there is a parallel piece of work about to kick off about online consultations as well, but that's just getting started. So what am I going to talk about? Primarily, I'm not going to talk about appointments and repeat prescriptions, and I'll show you why. I'm going to talk about this GMS contract requirement to give patients, or offer at least, online access to summary information in the record. And there is a strange thing, which is a sort of a non-contractual agreement for practices where possible to extend that to full record access. But that's not a contractual requirement. So basically what I'm going to talk about is the logistics, how do you get yourself organized, how do you get started about doing record access, and then I'm going to talk about the why should you do this, and I'll explain what that means later. But first of all, can I just say amongst the audience here, how many GPs do we have? And how many of you are actually involved actually on a day-to-day basis with patients having online access? Great. Please do stop me and ask questions at any time. I'd rather take them as we go along, and this applies to everybody. It's a big area. There are lots of little nooks and crannies of detail about how to do it right. I can't cover them all, so there might be gaps. I might say something that sounds absolute rubbish, and I probably will. I usually do. So just stick your hand up, and I'll try and deal with it as we go along. So this is why I'm not going to talk about appointments and prescriptions. In some ways, we've done it. General practice has done it. There's 11 million patients signed up. This is in England. So think about what a proportion. That's about 20% of the population that could sign up. Probably more than 20% of the population that could sign up to have some form of record access. And that's really happened in a couple of years. It was beginning to grow before the contractual requirement came in, but it has taken off since. 78% of practices have got more than 10% of their patients signed up for some form. And just out of interest, does anybody know how to access NHS Digital's public data about how your practice are doing, or what your practice are doing? There's a really good little bit of the NHS Digital website called the GP Data Hub. And that provides all sorts of data on a by practice basis for the whole of the country. And included in that is your practice's take-up and use of patient online services. It's under the patient online management information bit. You'll easily find it if you just search out the GP Data Hub. Some of these slides have got links on, and some of them are quite wordy, but that's partly because I know that you'll have access to the slides, I think, afterwards, and so don't bother copying links or anything else I show, because you'll have access to that when you get access to the slides. Records access is nothing like 11 million. It's about 1% of the population. But that's grown quite a lot over the last 18 months. But part of my point of talking is to look at why it's so much lower than appointments and prescriptions. And just out of interest, all those of you that are involved with online access for your patients now, how many of you are actively encouraging people? I mean encouraging, not just signing up when somebody asks for it. 1. 2, excellent, good. Hopefully I'll give a good explanation towards the end of the talk about why it's really helpful to recommend it to patients. So we did a little survey. This was last summer. And it's more qualitative than quantitative. To be honest, it wasn't very thorough. We basically put up a survey monkey, circulated the normal people connected to the college and said, if you're thinking about online or if you're doing online, why would you recommend it to patients? And we got 211 replies, which broke down in this way. Most of them practice managers, but actually a pretty good number of GPs and very, very few, almost no nurses. And this was the record access that they were offering. The bottom line there, medication ADRs, that's the early summary information that was asked for before the contract said record access. And these were the reasons why people would recommend record access. This is what the survey responses said. And this was 84 out of the 200 said they would recommend, not just sign up people when they ask for it, but would actually actively recommend it. And the top three are quite interesting. So that people can see the test results, see what is in the record, but self-management of long-term conditions. And to me, this is the crux of why I would recommend online access to patients. So this is, I'll leave you to read that, written by somebody, a patient, who signed up to record access. I really like the metaphor of the passenger. It sums it up to me. In short, I'm no longer a passenger with access to my records. I'm now very much part of the management team for the effective treatment of my condition. In his case, it was ulcerative colitis, this guy. Right. So, if you're going to sign people up for record access, if you're going to encourage record access, how are you going to get started? Are you doing it as well as you can? Preparation, as with all things, is pretty important. And I would recommend the Royal College website for guidance, pro formas, templates, and some really, I think they're very good because I've had not an awful lot to do with them, the actual e-learning modules, not just the documents. So think about your record data quality. Think about it prospectively. Think about it retrospectively. If there's mistakes, if there's contradictions, if there are ambiguities, if there are things that people may seriously misunderstand, then maybe there's something to be done about that. And think too about how careful you are about not recording subjective opinions, normal for Norfolk, or in my case, normal for Yorkshire, or third-party confidential information. You know those letters you get back from case conferences where 3 kids are talked about in one letter? Patient information. The patients actually, the more they know about how the thing works, about how to do it safely and effectively and securely, how to make sure that other people don't get access to their records, to be aware of the risk that they may be coerced into allowing access unwillingly and harmfully. I'll come on to that a little bit more, so that they have the health literacy to understand what they're seeing on the screen, and also what to do if something upsets them and who to go and talk to, and the practice attitude to somebody coming along and saying, look, I'm not happy about something I've just seen on my screen. It's a team effort within the practice, and the team needs to know what's happening. Most important of all, probably the receptionists on the front line need to know what to tell patients when they ask about it. But they also need to know what their roles are in the process of signing people up and maintaining it. And as with everything, You've got to write it up, otherwise the details can go missing and things can go wrong. And then you want to promote it. There's actually some really good resources, like Wonderful Balloons, on the NHS England website, and you can easily order those. Leaflets, posters. The practices that actually get most benefit from online access are the ones that put some effort into promoting it, not just do it secretly. The registration process. The most used guideline, the most hits on the website are about identity verification. How do you know that the person you're signing up is the person who they say they are? These things are actually probably going to change. So what, if you've ever used NHS England or college advice on identity verification, there are going to be some subtle changes coming along. And they'll be going on our website fairly soon. NHS Digital have a process going about online citizen identity. And that covers identity verification when you first get your log-on details, and then how the authentication process works when you want to access your records. And those are the 3 ways still of identifying people on the screen there. Photo and address proof. Now that can actually be one document, doesn't have to be 2, which is what it says on the one document will do, as long as both the photo is like the person you're looking at and the address evidence is the address you've got on your records, or you know why not. So, why don't people want to sign up patients for record access? What puts practices off? And these are the reported commonest causes, reasons. There is the huge safeguarding risk, and it is significant. A really, really good way for an abusive partner to manipulate their partner is to control their access to healthcare. I know the police, having talked to 1 or 2 police, senior police in this area who deal with abuse, domestic violence, they're really concerned about the impact of online access and what a partner might see, and the fact that if the partner who's abusing can see what's on the record, they can monitor what's being said at the doctors. So confidentiality can go out the window. People are concerned that their records contain something. Practice is concerned the records may upset the patient, may contain something that's harmful. Maybe they'll be in there somewhere, there'll be a reference to somebody being adopted that the person doesn't know. These things can happen. There could be diagnoses that they've forgotten, serious diagnoses that they've underestimated and become a shock when they see it in print on the screen. And of course they're worried about giving access to the wrong person, the identity verification issue. So, if you're going to give access to the records, and there are these fears about the data harming the patient, upsetting the patient can be knocking on your door saying, "You're wrong, how dare you write that about me? I've not got a personality disorder, and I'll thump you if you say I have." And somebody's scanned and attached the letter to the wrong patient's notes. That's probably one of the commonest reasons for third-party data to get into the records. And if the patient's got access to the clinical correspondence, bingo, problems arise. So, how do you deal with that? In preparation, it needs to be a practice decision to be really careful about potentially harmful data as you record it. All the systems have got some way of hiding data like that so that it's not seen online. Think about it if you come across something that's about someone else, not the patient. And remember, the systems don't actually tell you if the patient in front of you whose record you're looking at has got online access or not. You won't know. And if it's somebody you don't know or somebody else has signed them up, then you may not know. So you have to assume that everybody who's in your practice, once you start giving record access, has record access. If they don't have it now, they might have it next month. So get used to recording, to redacting stuff. Sometimes you'll get something that you know the patient may not know about, and yet they've got an appointment in 10 days, but you want to talk to them about it face to face. So you might redact it for now, talk to them at the next appointment, and then remove the redaction once it's not going to be a shock to them that they've got a bad result sitting on the record. These checks need to be done before you register the patient, but it's not just a matter of looking through the record, redacting it, or saying, fine, that's good. There's actually often a need, if there is something that's worrying, to talk to the patient about it, discuss it with the patient, preempt any signing up of people to say, look, there may be things up in here that upset you, talk to me. If you see something on a Friday night that's very new in the record, I might not have had the time to see it, don't get scared. Usually it's nothing. Come and ring us up first thing Monday morning. Give them some idea it might happen. Give them a way of managing it. Tell them you're aware, you're concerned, you'll try and help them with it. And then, I've talked about vulnerable patients. I've talked about coercion. There's an awful lot of abuse that we never know about. It's almost impossible to know whether abuse is going on and who the abuser might be and what access that abuser might have. So it's a good idea to at least make sure that it's part of the practice policy for whoever deals with that last sign-on thing and at some stage hands over the log-on details, or even before that, says, do you have any concerns that somebody might want to access your records against your wishes? Do you feel any pressure at home or anywhere to show your record to anyone else? Some kind of little question that just gives the patient the chance to say it when they may not say it if you don't raise it. And when you register them, the form, the Royal College form that you might want to use, which you keep in the records, which is, if you like, a data sharing agreement almost, that's got a little box in it saying, has this question been asked? Should be ticked. Ticked and done. Okay, so that's the start. Records and record quality. I've talked about record quality, and Di over here is going to tell you far more about it. But the records do need to be good, but they need to be a definition of data quality. Record quality is records fit for the purpose, but it's never purpose. It's loads of purposes, and this is a new purpose. So it's going to change the concept of what data quality is. And it does change it. It doesn't actually make anything different. It makes you think about it in a slightly different way. So I've mentioned being careful with harmful, sensitive data, third-party data. It does suggest that it's good to use structured data entry because then you know the codes are clear-cut, they're not ambiguous. Obviously, it's only part of the time, but it does give a boost to using structured data entry where you've pre-thought about the codes to be used early on. Remember that this is a communication process now, not just within the practice, not just when you refer somebody, but you're now communicating with the patient. And there are things that are really helpful to code. I'll give you an example later on, but one of the classics is preferred place of death. If the patient's end-of-life care and they can see it on their record, they know what it is, they know if they change their mind that it's worth changing it, so the practice knows. It really, really helps those kind of communication issues. Things that might get missed, might get not thought about, might get forgotten. And this is an ongoing process I alluded to earlier. It's not just, oh, we'll check it when we sign someone up. It's all patients all the time, ideally. And if you're going to give access to more than the codes, which have to go back to the year dot, that's the contract, but that contract doesn't say that about extended access. So if you're going to give extended access to word process documents and correspondence or consultation pretext, and there are benefits, I'll talk about those, think about doing it from now. prospectively. And that takes out a huge chunk of all that checking you'd otherwise have to do for harmful data in the past. How am I doing for time? Great. Big task, health literacy. We all know what lab tests mean. We all know what a normal test means. Sometimes normal tests are abnormal for that patient. Sometimes abnormal tests are normal for that patient. Yes. No.
Can we have the microphone just before you, as you're not available on it?
So just regarding this distinction between coded data and free text / correspondence,
Yes.
is that likely to change contractually in the coming years, do you know? I mean, I know at the moment it's like that, but the DOH has a habit of sort of shifting the goalposts.
They do. Policy and law can be changed by government. So I'm not aware of any intention to change it. I think at the moment, anything that made GP's job more onerous would meet a lot of resistance, but I think that's the best I can say.
Okay,
but
you're
I'm not aware.
of it,
I'm not aware. And it's not just a matter of you spending time improving the patient's health literacy. They can do it themselves. 75% of people use the internet for health information at some point. So if you can focus them, if you can give them some good places to go, and these links will be with the slides when they're made available. These are just some examples of some very good websites that people can use for specific purposes. This is about person-centered care. Collaborative care, it's being called increasingly. If any of you read the BJGP from time to time and remember all the editorials, there was an editorial last year. Nigel Mathers is the secretary of the Royal College, and he introduced this concept of the House of Care, which is a model to describe person-centered care from direct provision of care through to commissioning at the other end. And sharing records is very much part of this left wall, engaged, informed individuals and carers. And it does say, and in the policy about collaborative care from the college, it really emphasizes how key sharing records is to really achieving patient-centered care. This is a plug, unadulterated advert. This is the toolkit that you can use to learn more than I've talked about now. And this is, I'm going to talk about some specific now clinical use, and I'll crack through this because we're running out of time. The slides here don't need to read. They're all in one of the e-learning modules, the one about clinical uses of record access on the toolkit. And they work through case studies to exemplify 3 common uses of record access for the patient's benefit to improve outcomes. And this is a simple process of looking at how patients can look at their own results from DMARD monitoring for rheumatology diseases and how the practice might manage that. Patient needs to understand the results. They need to understand what to do if the results aren't what they expect, if they become abnormal. They need to also know about what symptoms might be an indication of a problem, which may make a small change in results important. They need to know when to come to the practice. They need to know how to and when to let the practice know that they have actually looked at the results. Because what you're doing here is saying, okay, we'll take the blood tests, result go online, we'll see you again next time you have a blood test, we're not going to bother to ring you up. And it's saving work. It's empowering the patients. They're becoming not passengers, but active participants in their care. But you've got to get a lot of things sorted up to do it properly. The website does have a very good description of all the issues that you need to think about. And then long-term conditions, clinics like diabetes mellitus. My practice works by the patient coming along, seeing the nurse, blood tests, educational stuff. May not need to be seen again, may need to be seen by the nurse, may need to be seen by a doctor later. But that second consultation works so much better if the patient's looked at their results online, knows what the issues are, knows what they want to talk about, comes in with their agenda prepared, has done some research, and everything gets so much easier and quicker. And the patient is getting feedback all the time and understanding what's going on. End-of-life care. You think, oh, hang on a minute, that's not long-term condition, but think about this. Actually, I don't know if any of you have been in the situation of caring for somebody at the end of life, not looking after them professionally, but actually caring for someone. The hardest thing, I think, and this I'm speaking from experience here as a doctor, is that you're suddenly not a doctor anymore. You're just a family member. You don't have access to all that information that you would just live and breathe if you were caring for the person. And it's so frustrating to not know what blood tests are, who's talked to who, what the test results were until you get an appointment. It really gave me empathy for the benefits of access, not just for patients at end of life, but access for their carers. Even simple things of ordering a repeat prescription is so much easier if you can just do it online and go and pick the prescriptions up. It just cuts down the tasks that a carer has to do in those last months or weeks. It's also really good because it's a way of achieving that multidisciplinary communication. Patient goes to the oncologist, talks to the Macmillan nurse, district nurse, aromatherapist, ambulance driver. Here's my details. Patient may not be able to talk about a power of attorney that somebody has got. They may not be able to talk about their preference about where they want to die. But they just have to be able to show them an iPad. And the health professional can know the background in ways they wouldn't do. There are ways of communicating this within the system, but they don't work everywhere. They don't always work as well as they should. People don't always use them. But if the patient or the carer has got the iPad, it can work well. So, end of the day. I always like to put a holiday slide in somewhere. It's not Blackpool, I can tell you. This is online record access. It's about patient-centered care. It's about improving self-care, self-management. It has a byproduct of improving the practice's standards for record quality. It makes you think a little bit more about what you're putting on the records. It really does support multidisciplinary working because it's not just the GP and the patient and the carer, but lots of other people have good, safe access to the data when they need it. But there are practice implications. There is some workload involved, and you do have to be wary about giving access to vulnerable patients. I'm not saying you don't give it to vulnerable patients. It may be that somebody is at risk of being abused, and you just want to make sure you redact everything that might be related to that abuse, so that there's no indication to the abuser that the patient has ever talked about the abuse. You can redact the consultation, you can redact the codes. You can even limit access to some patients where you'd give full access otherwise. So I think that's about all I had to say, and I'm probably out of time.
Perfect timing, Ralph. Thanks. Have we got any questions? Wait, if we can go with the microphone.
I'll be quick with my answers.
Tom Nichols from Oxfordshire. The thing that I find difficult to convey to people is the perceived risks. In reality, I believe that, I like the way you describe them as perceived risks. I would like to have vignettes, rather than the vignettes telling me about the advantages of this, which are so obvious to me that I don't need to describe them. I want the case studies of times when it's actually gone wrong, because the learning points that I need to bring out of that to form my policies and give people advice and encourage them come from the times when the police actually found that somebody was using patient access as part of their abuse. Because the theoretical risks, I wonder, does anyone have any significant events?
Significant events? I've started, personal experience, I started giving patients full record access about 10 years ago. And I negotiated not giving one patient record access because I was really concerned about the issues because that patient had a paranoid schizophrenia, which is quite unstable, and I could see it being potentially harmful. And actually, she agreed that she may misinterpret it, and perhaps actually I'll not bother, doctor. So it was not a confrontation. That was a concern. But actually, no. To be honest, I'm not aware, and the people I've talked to about it have not come up with a whole host of problems arising. But actually, the problem is a lot of it could be out of sight, and we're not aware. So I think even if there's not a lot of evidence, and to be honest, there's very little research on UK-style, this kind of patient access. There's no way of reporting bad events, and how do we get to know about it? But the risk is there, and there are major concerns, but they can be managed. So the toolkit has one long piece of guidance about all the issues and solutions for the issues. But awareness, I think, is the most important thing. But no, I can't give you hard and fast examples of times when it's gone wrong.
Ian Herbert, Ralph, brilliant, lovely talk, really nice. How sophisticated are GP systems at handling the permissions to see third-party data in the record? Because I remember Amir saying that basically he just rode the horse and let it go on running and would have and took the flak if anything went wrong, and it didn't. But it could easily do so. Third-party data is a real problem. Now, definitely in some cases, patients will want it shared. Elderly patients with their wife, relative, whatever, their carer. But in other cases, it's quite tricky. And I don't know whether system facilities support the kind of sophistication of saying, e.g., that this person may see this data, and whether it's too elaborate to use in practice anyway.
Systems work differently. Some systems work better than others, I have to say. And with the coded data, for example, if you in one system, if you redact a code, then all linked consultations with that code as a problem title are redacted. When you say redacted? Well, redacted is, sorry, if I've not explained it, what you're doing is you're hiding that record from display outside of the practice. So it doesn't go with data sharing to the local A&E department. It doesn't go to patients. It doesn't automatically go on printouts. And it's a click confidentiality button. It works. It's more fiddly in some systems than others. And it's much more of a problem once you get into correspondence and into free text than when you're dealing with codes. I did say to you, there is at least one system where you can, as part of, there's a fee, an annual fee, but as part of the suite of tools you get, one is it runs a search for codes that may be harmful to patients. Gives you an idea of whether they're there. You still need to eyeball the record because of third party, but it gives you a feel about whether there's a lot of issues or not. So it does help. Go on. No, later, there's somebody here first.
Hi, Ralph. Marcus Bohr, I'm locum GP. I was involved in the original work group with the RCGP on Patient Online, which was 4 or 5 years ago now. I just wanted to pick up on something you said before about there being no mechanism for reporting adverse events that we think are related to this. Does that alarm you or concern you? Because it concerns me.
Absolutely, it does. Interestingly enough, these things are often breaches of privacy problems. Now that, I would think, technically should be reported to the ICO within 72 hours under the new European legislation coming in next year. Whether this will apply, I don't know. But there are standard ways of reporting significant adverse reactions to drugs. There isn't an equivalent for this.
Do you think we need one?
I think that's a really good question. Need is a black and white yes or no, isn't it? So yes is the answer. Level of importance, not sure. It depends really on what you're trying to persuade, who's going to use that information once you've got it. It is a good question, what's the hard evidence? Because I think a lot of this will never become evidence because it'll happen under the bonnet, I think you have to think about it anyway. But you're right, it's a good point. I will think about it more and talk to people.
One more quick question, and then we probably ought to move on.
Julian Costello, sorry, just a correction really. Your tool to help identify data that perhaps shouldn't be shared is available. I have some interest in that.
I was going to say you would know.
Yeah.
Yes, yes. Yeah, I didn't
It's
realise
available
it
to all
was.
the system suppliers.
Yep. Through the
current suppliers.
Yeah. Ask Julian if you want to know more. I didn't want to cover those sort of issues, really.
Thank you very much indeed, Ralph. Very informative.